session where we will be exploring the intricate world of objective measures of sleep. We will also be exploring types of sleep studies and the theory behind polysomnography. This session will be led by Dr. Christina Franz-Nam. So let's get up for this fascinating lecture. Thank you, ma'am.
Good morning, everyone, or should I say good afternoon. We are now having two small lectures on sleep studies because you need to understand what type of sleep studies exist and how we are going to interpret them, okay? So now I'll give you two short lectures. The first one is the objective measures of sleep 1. We have 4 types of polysomnographic examinations. Let me get it here. Polysomnographic, the word comes from poly means many, somno means sleep, and graphic means writing. So these are different ways of having the sleep, the whole night sleep written somehow, so we can understand what's going on with the body. Okay? So the one that we are going to talk about right now is the type 1. The type 1 is a fully attended PSG. It has more than 7 channels and is made in a lab. Is this sound okay? Is this sound okay? Yeah? Okay. Type 2 is the same thing as type 1, but it's not in a lab. It's made at home or in a hospital. It's made in other settings. The type 3, we are going to deal deep in each one of them right now, okay? The type D is also called the polysomnographic and has a limited channel study. So we have less channels to study. And finally, the type 4, that we have just 1 or 2 channels, usually is a high resolution pulse oximetry is one of the parameters. So this is something we all must know, because patients will come to us having one of these examinations, and they will never know which type the exam they bring into us are. So we have to just look at it and see what type is to put in the, I forgot the name. When the patients come to us, we have to write an evaluation. So we have to, we write everything to keep it, the assessment. So we write the type of the study, thank you, that the patient came in the assessment. Always do that. Write the type of the study and the date the study was performed. So now in this first lecture, let's talk about the full night polysomnography and the types that exist of this one. So this is what we call the sleep study, the type 1, the complete one, the full night. It has 7 channels, including the EEG, the EMG that can be in chin and in both legs, the EOG for both eyes, the ECG for the heart. We have complete respiratory evaluation. I will go very slowly so you can copy or take pictures of everything, because this is simple in a way, but it's very important for us. So the respiratory evaluation, we will have the airflow and the respiratory effort. And I was sitting there at the first lecture of Professor Zubia, listening to all of you asking about snoring. And we can see the snoring here in the polysomnography in two manners. The first one is that we are going to see here a flattening of the airflow. And the second one is that the microphone will record the snoring, okay? We'll talk about the snoring deeply tomorrow morning. We also have the oximetry, so we have the saturations rates for the whole night, and body position is objectively measured. And why do you think body position is important? Because many of the respiratory events, they can occur related to body positions, okay? Not only obstructive ones, but also central ones. So these PSG can be made only in lab and at home. This is the type 2, and in lab is the type 1. We are going to see the difference between them. The type 1 is the one that is made with a technician observing you all night long. So while the patient is sleeping, there's one technician that stays awake all night long observing that to see if an electrode comes out, if something went wrong. They go into the room and adjust it so we have a proper examination. Type 1 is also important because we have the possibility of having audio and video recording. And sometimes, for some disorders, video recording is very important. Remember that on the first day, we talked about the REM sleep behavior disorder. Sometimes this disorder can be seen sometimes it is a little bit difficult because the behavior needs to happen on that specific night that the subject is sleeping at the lab. So our nights are not equally, so they change a lot. So if the behavior happens in that night, the video will get it. And we will see the REM sleep behavior too. But it has some terrible things. Has anyone here has anyone done PSG as a subject, as a patient? Yeah. Yeah. Is it good? Did you sleep well? Why? What happened?
There are so many records on your head and chin, and the chest is completely lined up. So it is not comfortable at all.
Yes, it's not comfortable. And the thing that I found most difficult for me was that fingertip pressing, the oximeter pressing my finger all night long. So I was changing that all the time. So that fragmented my sleep. And of course, it was not my bed. It was not my sheets. It was not my pillow. I knew someone was watching me all night long. So it is very, very strange. Sometimes patients tell that they don't sleep well because of different environments. But I've heard many patients say, oh, that was the best night of my life because they were out of home, out of husband, children, dog, and everything. Like being in a hotel and knowing that if something happens to your body, someone is watching you, so relaxed a lot. So we have these two types of patients' opinion about the type 1 polysomnography. Well, I've been a volunteer for many studies in Brazil. So I've done, I think, more than 10 PSG as a volunteer. The type 1 is, the type 2 has the same channels as the type 1, but this is unattended. So is in terms of price is better, but you don't have the technician to observe you during the whole night. So when a physician asks or prescribes a patient a type 2, the patient needs to be informed that there is a 50% chance that they will need another exam. Because imagine that the patient is sleeping and then one electrode, the eye electrode, for example, comes out. So we are not able to measure a very important variable. In this case, the exam has to be performed again. So in the type 2, it's not obliged to have electrodes in the legs and the body position. But often, at least in Brazil, they do have. And it depends on the position of the electrodes on the scalp, on the leg, in the whole body. So they have to be very well attached. And it's difficult to attach them in the hair, okay, in the scalp because of the hair. So sometimes they drop out. But the good thing is that the patient can sleep in their own environment. So for children, it's a good opportunity, okay? And maybe for some patients too. Well, this examination, the polysomnographic, has higher costs, can be interfered by many artifacts. It has a huge variability between the nights. And we can also have this laboratory effect. That's exactly what he said. Maybe the patient sleep well at home, but when goes to make to perform the PSG, the patient will say, it was the worst thing in my life. What are these many electrodes and things like that? So it might not reflect, and in the majority of the case, it doesn't reflect the perception of sleep of the patient. But it's interesting because we have the full screen of what's going on with that body during sleep, okay? But one thing is kind of very important. We treat the patient, not the PSG, okay? Because many times my students come and say, oh, this PhD, this PhD, that, and I said, okay, and the patient. So you will find, as I said before, different complaints that doesn't match to what you see in the PSG, okay? So PSG is the gold standard evaluation for sleep. In Brazil, physiotherapists can prescribe a PSG, but as I told you, I happily encourage everyone not to, because we need to have a physician together. So the first variable is the EEG. The EEG is able to get if you're waking or if you're asleep because of its waves. And then we have all those sleep stages that we talked about. These two stages, REM and non-REM, and N1, N2, and N3. And each stage has its specific brain waves. So the technicians see the waves, and we have specific rules determined by the American Academy of Sleep Medicine. And the technician can read these waves and create a final report that the physician signs, okay? So we have the position of the exactly position of the electrodes in both sides, and then we will have these brain waves. So in this brain wave that you see here, that is a quickly one with a high frequency, small amplitude, is like we call the alpha wave, okay? That is very, very present when we are awake, like now. For you, I might be having some slow waves here because of the jet lag thing, but you, for sure, are having alpha waves. And maybe we also have some beta waves. When we enter the N1 sleep stage, we have a mixture of alpha and beta waves. So we see that our brains starts a little bit to decrease the frequency and to increase the amplitude of these waves. We can see it here and here. When we enter the maintenance stage, that is the N2 sleep stage, we have those grapho elements, the microstructure of sleep, that as we call, that are these bursts called the sleep spindles, and these key complex. They are both related to a deep sleep and related to losing the senses of our body. Okay, they are very important for dream itself. So we have a mixture of all these waves in this stage. And when we enter into N3 sleep stage, we have um, we have high amplitudes of these waves, and they are very low. So our brain becomes, in a way, with low waves. That is why it's called slow wave sleep. And finally, REM sleep. See how it looks like. The brain, the waves looks very like when we are awake. So here we have very quickly waves with higher frequency and low amplitude. Okay, so this is something that we must know. So when he performed his polysomnography, he was looking like this one with lots of electrodes in it. So he had electrodes in the eyes, in all over the scalp, in the heart, sensor for body position, a belt for body movement, a belt for abdominal movement, the thing that was annoying me, my finger, and also electrodes position in the chin for diagnosis of sleep bruxism, and in the limbs for diagnosis of not RLS, PLMS, and PLMD, okay? So now I'm going to show you in this patient that we had at the sleep lab, each one of them, how they are positioned. So very quickly. So here we have the position of electrodes in both lateral of the eyes. So at the beginning of the sleep, we will see the slow ocular movements, and at the REM sleep stage, we will see very fast movements of both eyes. And we can see here in these blue waves that the eyes are here, the left one and the right one, okay? So we see how they are moving during the whole night. Then we have this nasal cannula that I'm sure many of you are very familiar with. And it's placed on, into the nose, and it serves to diagnose hypopneas. We are talking about that tomorrow, but pnea comes from the Greek word that means stop breathing, absent breathing, and hypo means reduced, less. So hypopnea is a form of apnea that we have a reduced flow, a reduced space for this flow. So here with the nasal cannula, we have this curve narrowing of 30% that must be associated with a drop in 3, and sometimes they say 4% of saturation and awakening. So these variables are not analyzed alone. they analyzed in a collective of variables. So the variables are analyzed all together. The apnea, stop breathing per se, needs to have a 90% of narrowing of the curve, and is usually seen in the temperature sensor that we can see here. Sometimes we have only the nasal cannula, and sometimes we can have this thermistor. Then the pulse oximetry that stays on during all night will, of course, detect the saturation. And here we have the belt, the abdominal and the thoracic belt, to detect the respiratory effort, because this is something that we can distinguish if if the event is a central or an obstructive apnea. So how do we see this difference in the thoracic belt and the abdominal one? When we have obstructive sleep apnea, does my thorax and my abdomen moves? Yes. They move? Yes? You sure? I stop breathing. I will stop breathing. See, they don't move. Okay? So when I have obstructive sleep apnea, these belts show no movement. When I have central sleep apnea, the brain stem stop breathing, stop signaling the breathing. But I do have this effort. Okay? That we try to breathe. The breathing is not happening, but we try to breathe. And then we signal again to breathe again, otherwise we will die. We'll talk about that tip tomorrow, okay? Yeah, because this is a very important difference between the two. We don't have this effort. So we can see this here. And it annoys a little bit to sleep with these belts. Also, patients complain of turning to the sides because all of these electrodes and belts. Well, we have the microphone attached here to capture the snoring and somniloquy, when the patient maybe sometimes speaks during the night, during his sleep. It can record it. And we have the electromyography. The picture is showing only the chin, but we can also have in both legs. It gets all the movements of these muscles during the sleep, and is used to diagnose the movement disorders that happen during sleep. The heart rate is another very important variable. And then we have the body position sensor, that is attached in one of these belts. So the PSG examination, it involves basically 3 huge steps. The first one is preparing the patient to make the exam. And then we have the overnight monitoring, or in case of type 2 study, the patients go home and then come back with the device. And then we have someone reading and scoring this examination. I think here is the same thing, but in Brazil, we need to study a lot to become a sleep technician, and we have a specific accreditation for that. So any health practitioner can be a sleep technician, okay, in Brazil. You just have to do a specific courses for that and pass the accreditation exam. I am not. This is not something that I like doing. I like patients. I like to be with them. But I need to know a little bit of these things because sometimes we see different things in the examinations and then we call the physician, we call the technician to discuss. So they do the scoring. And here I brought some measure variables just for you to see the EEG, how it looks like. For example, an arousal. It will look like this thing here. So we will have reduced amplitude of the brain waves and with higher frequency. When we have a burst of muscle activity, can be the legs or can be the chin in this example here, we have like this thing showing up here. This is very common in the bruxism and PLMS exams. The nasal airflow, we will have like this stopping breathing here that will be an apnea. And when we have an apnea, we will see a paradoxical movement. Sometimes we have this movement down here that is captured by the abdominal belt. And sometimes together with the apnea, we can have a desaturation. We might have both bradycardia and tachycardia in the exam. Here is showing only bradycardia. So in the PSG report, we will have all these graphs, but we will also have the statistics that makes everything easier for us to see. So I asked a friend to give me an example of how she was reading. She is a sleep technician and she's also a sleep physiotherapist in Brazil. And she's the one who reads and scores the PSG in the lab that I work with. So there is no sound here, but you can see how it looks like. Don't be scared. The first time I saw this, I was, oh my God, what am I doing here? She's scoring. So she goes through the whole night in these things that we call windows and see how everything is going on. Just stopping a little bit to show you. Okay, here, for example, what we have here in these black ones are the brain waves, okay? Here in blue, we have the left and the right eyes, okay? You see left eye, right eye. Queixo in Portuguese means chin. So here we have the chin. Oh, see, we have something here. A little movement here. Oh, okay, this patient has bruxism. No, it's just one movement. To be bruxism, it needs to have a pattern to repeat a lot of times. So maybe the patient was dreaming and said, okay, I want to go back to India. Something like that, I don't know. But so we have to be very careful and score the exam all night long. Here we have the heart rate, okay? And here we have the left leg and the right leg. So we see here the nasal cannula, the thoracic belt, the abdomen. The respiratory effort is here in this line. And here we have the saturation of the patient, 91%, 90%. Here we have the pulse. And in blue here, we have the snoring. Okay, this blue line here shows no snoring now. In here, body position. S stands for supine. Okay? So we see how this changes during the night. Oh, see here, what's going on? We see chin is moving a lot. And I also have leg movements, both leg movements. But I had something here in the cannula. See how the brain waves change because of this movement. So I have here the saturation gone down 89%. Yeah? But the position stays the same. So they, let me see if I can stop it here for you. Okay, oops. See, a lot of things going on here. So this is something that we can look for hours to try to understand what's going on. And this is only 20 seconds of the whole night. So what you see now is only 20 seconds. So the PSG technician sit the whole night. So imagine how many seconds they see. You see those markers here at the saturation. It marks automatically when we have this saturation. So there are two ways of having the PSG scored. An automatic way that we call automatic. The system does itself everything, but we don't trust that much. And the eye, the human eye. So the PSG stays like this and it's going right in everything and everything is ready. So it's an amazing work. I could never do that. So you see those blue lines here? You see these blue lines? What is this? Snoring. So it goes like, it goes like that all the night. Okay? So meaning that the patient has a lot of difficulty in breathing. Oh, sorry. You want to see that again? Okay. And she stops the window to click to see something else. So the scoring of the events are going on. You see that sometimes this video stops. It's not me. It's because she stops it to see one specific channel. And she can go to the snoring, for example, and amplifies it to see how much this happens. So you see, she's on the chin now. See, the arrow is at the chin. So she was scoring and she saw that something was going on in the chin. So she was attentive to that. So yesterday, someone, I think someone asked me about how do I know if it's a PLMS or if the patient is just turning to one side to another. We will know because we will see the brain waves. So if the patient is on N2 on N3 stage and has a pattern of movement in the legs, then this will be a PLMS. But if the legs move just once, then we'll be just maybe turning or something, okay? So we have specific rules And they are kind of very complicated, to tell you the truth. Specific rules for each of the events. So I love this PSG examination because we really have a great picture. Now, let's do some exercises. So this is hypnogram of a PSG of one of my patients. And here, what you see is the hypnogram per se. So we also have the colors universally the same to try to make things easier. So up here we have the wake stage, then the R stage or REM sleep stage, N1, N2, and N3 shown here in green. I know it's too small, but can you tell me how many bouts of REM sleep stage did this patient had this night? Yeah, okay, almost 3. 1 here, but there was here some shifting to N1 sleep, okay? So 1 bout here, and the second one here, and just a little bit here. These lines here means arousal. Here you see 0, 15, and 30. These are the seconds. So the height of these lines means how long this arousal lasted. So this patient had any arousals? A lot. But why? Let's see why he was wakened during the night. No periodic, no PLMS, okay, here, no. Now here we have in red the obstructive apneas. So each one of these is in seconds, for how many seconds the event lasted. So looking at these here at the bottom, you see the hour. 9, 10, 3 in the morning, 7 in the morning, okay? So we have to read the exam like this. So this first half of the night, and this is the second half of the night. This patient had more obstructive apneas in the first or in the second part of the night? Yeah, perfect. And can you tell me which kind of stage happens mostly in the second part of the night? Yeah. REM sleep stage. Okay, perfect. Has this patient have apneas only during REM sleep stage? No. No, perfect. So this is how we understand, we interpret the polysomnography. We start looking and trying to combine things to see what's going on. These pink ones are the hypopnea events. So you see this longer here? Wow! It lasts much more than 20 seconds. It lasts about 60 seconds. It's one huge one here. And there's another huge one here, okay? This huge one, red here, this huge red one here is the obstructive. So these here are the hypopneas. The blue ones are the central apneas. And in blue here, we see this desaturation. Does this patient have a desaturation? A very important desaturation. A very important. You think so? Yeah, I don't think so. It has a little bit here, yeah, and a little bit here. Are they related? Are these desaturations related to any specific sleep stage? Looks like, yeah. So we see the desaturation here, and when we go up, oh, we see REM sleep stage here, and we see a lot of hypopneas here. Here again, we see the desaturation, we see the hypopneas, we see obstructive apneas, we see arousal, and we see REM sleep stage. So tomorrow we are going to discuss what happens to the airway during REM sleep stage. And how is the heart rate? Is it functioning properly? No. I say to my patients that when they have a respiratory event, it's like their body wants to sleep, but the heart wants to run a marathon. But it's not a good marathon that the heart goes in a very good way. The heart go very fast and then stop, and then go very fast again and then stop. So it's something that with the years will of course damage the heart. And here we have the posture. So supine, prone, and turning here to the left, okay? So this patient was almost all of the night in supine position. This is another thing that is completely understandable, because during the PSG examination, because of lots of things, patients sometimes are afraid to turn to the sides or to adopt their preferred sleep position because they are afraid something else is going to drop off or something. So patients say, I slept very bad because I stood still all night long. So this is a common thing that you will see. So when a patient comes to me, the first thing that I like to see is this whole picture. I always tell them, this is the picture of your sleep. And I explain through this. I explain this to the patients. I go through these variables, just like we did here. I explain this to them. Yeah, but things in sleep world, they are not so every time so easy. So things get a little bit complicated now. We have this type 1 PSG, but we also have different montages, different ways of this PSG. So this one that I just showed you, we call it basal, baseline. Is a basic one. Is a picture of how the patient sleeps. I'm not doing anything. I'm just checking. I'm just taking a picture, okay? But we also have some specific PSG type 1 for PEP titration. We are going to see some examples now. We also have intraoral device titration for the PSG. We have a split night one, that is half a baseline one and half PEP titration. If the physician or the dentist, or if we suspect that that patient comes with morning headache, with neck pain, with lots of pain in the face, or if we see in the intraoral examination, we see the teeth like broken and having all those things, we can suspect of bruxism, and then we can ask for a PSG type 1 with a bruxism montage. I write just like this to the physician or to the dentist. I suspect the patient has sleep bruxism because of headache, of pain, etc. And please, what do you think about conducting a PSG type 1 with bruxism montage? Sometimes my colleagues, physicians in Brazil, they call me and ask, how do I write this whole thing? And it's just like that. You write that, and the technician will know exactly what you want. Also, you can have a specific montage for parasomnia, that you have the EMG in the arms, for example. So parasomnia is a disorder specifically of N3 sleep stage, that the patient can act or can make gestures while asleep, can talk, can have nightmares and things like that. We also have an extended EEG in case the neurologist suspect of epilepsy. So there are more brain electrodes. There's also a neurological one that has more electrodes than the baseline one, but less than the epilepsy ones. Okay. And we have the capnography that can be added in cases of hypoventilation, and the video recording. We can ask for a PSG with video recording. Okay? So these are different kinds of different montages, that, as we call, of type 1 PSG. So this is how a basal PSG looks like. Now you tell me, is there any desaturation? A little bit here at the end, okay? Are there any increase in heart rate? Perfect, at the end. Are there central apneas? Are there obstructive apneas? Much or less than hypopneas? Okay. Here, AM stands for mixed apneas, when we have both central and obstructive ones. In this case, we have none. Here are the sleep states. Oh, we saw a very similar hypnogram yesterday for an insomnia patient. Remember that? But if I look to this hypnogram, does this mean that this patient has insomnia? No, of course not. It just means that the patient took a long time to sleep. See, the exam started at 11 o'clock, and the patient went through the first stage of sleep about midnight maybe. So it took more than 30 minutes for the patient to sleep. Okay? Do you think this kind of hypnogram shows a restorative sleep? Okay, who thinks this looks like a restorative sleep? Raise the hands. Do you think this sleep is good? Is restorative? No, the opposite. Yeah. So this, we can see here that a lot of shifting the sleep stage during the night. This is no good. Then we can see here that are a lot of awakenings during the night. So you see here about 1 o'clock in the morning. There is no sign here. These are the signs for awakening. So the arousal. So the patient was awake here. That's because there is no arousal showing here. This patient had many arousals during the night. We can see here, and they were longer ones, okay? And the patient also was turning supine to the right side, supine to the right side all night long. So this is a patient who has obstructive sleep apnea, mainly because of hypopnea events, okay? So what we have to do here? How do I treat this patient? Okay, how do I treat? Maybe you don't know this answer yet, because we are going to talk this about tomorrow morning, but do you know that we have to treat this patient, okay? what are we treating in this patient? The respiratory events. So we have to treat the hypopneas and we have to treat the apneas. Okay, so imagine that both are treated. Okay, there is no hypopnea and no hypopnea, no desaturation, the heart rate is going well. What's going to happen to this hypnogram here? Will it change? Yes, it will change. So changing the sleep architecture is our main aim. And we are going to change that by helping the patient to sleep better. Okay? So if the patient has a very good sleep architecture, all the sleep functions will work properly. Okay? So this is another one. You tell me. Someone raise the hand and tell me what you see for the whole thing. In 2 words. Okay, not 2 words. You can tell more words. You want me to go through this again with you, or you can do it by yourselves? Okay. Okay, just one at a time. There are more hypopnea, like the last one. There are some obstructive events. Yeah, it looks like this patient desaturates more than the last one, at least in the middle of the night. The heart rate doesn't vary so much as the last one, but it varies a little bit, but during all night. So this is another very important thing. Yeah, more REM sleep. Yeah. Stayed awake here at 4 a.m. in the morning. You see the E here? E means left. Okay, so this patient turned to right and turned to left. No, no right, just left. Supine position and left position. But this patient had something that you haven't seen before in a PSG sheet. This is in Portuguese, that's why I'm translating to you. This is leg movements. So this patient here, in this dark red, has PLMD. Okay? So this is how the PLM disorder will look like. Okay? You see that this PLM disorder is somehow related to the respiratory events. So in this patient, we would first treat the respiratory events and then address the PLMD. Okay, so this is another one. A lot of desaturation. The heart goes crazy. Lots of apnea. Yeah, poor patient. Okay, this patient here is at a huge increase in his life. So this here needs immediately treatment. Okay, so you see the desaturation much more all night long. These events are so big. You see there is no sleep here. You see all the time the patient was awakened, having lots of arousals, turning around all the time, and having very, very poor sleep. Almost nothing of REM sleep stage, and see no slow wave sleep, nothing, zero slow wave sleep. Can you imagine how are the muscles of this patient. How is the memory, the cognitive function, okay? Perfect, you are doing great, I'm very happy. So I think this is the last baseline PSG. So you see here almost the same things that we saw, but this patient has less obstructive than the last one, more hypopnea, and also a higher index of desaturation. So you see these curves here, we call this hypoxic burden. So this is a marker. Maybe this hypoxic burden can be a biomarker. We were talking about biomarkers of sleep in the first day. And this hypoxic burden is for sure a biomarker of respiratory events. And we see this patient stays a lot trying to maintain his sleep. So it stays a lot during N2 sleep stage, okay? And why doesn't this patient have any events after 5 in the morning? Of course. Yeah, because he was awake. Perfect. Now let's see how a titration study looks like. Everyone knows what a titration means. Yes? Can you speak louder, please? Yeah. We titrate the PAP machine when we look for the optimal pressure of the device. And what is the optimal pressure? Is the less pressure that will make the patient have no respiratory events and saturate accordingly. Okay? So this is a window of a PSG. So this is a PEP titration without the PEP. So this is the baseline. And then when the PEP starts working, this is how we see. See the difference? So you see here the arousals, less arousals. You see the hypnogram going on here. And look how interesting this is. When the patient is on PAP, look at how much REM sleep stage it goes into. And then here we have the respiratory events. Let me see if you got that. The pink one stands for, the red one, the black one, yeah, and some blue ones here, central ones. Okay? Can you see the hypoxic burden that we talked about here and here and here? And let's see the respiratory events and the saturation with the PAP. Almost gone. Maybe we can increase a little bit more of the pressure. See here the snoring, lots of snoring, and then when we have the PAP device, less snoring. So the PAP device is here to correct the respiratory events, okay? I showed you the before and after hypnogram. Now I'm showing how is the PEP titration done in one night, okay? So the patient goes to the lab and the physician prescription is written PEP titration. So what the sleep technician needs to know is the optimal pressure that will treat the respiratory events of that patient. So you see here, you have the heart rate, the saturation, the hypnogram, central apneas, obstructive ones, mixed ones, hypopneas, posture, leg movements, and here start to show a pressure. In this case, it shows two pressure of the B-level device, but let's just stick to the one of them, okay? So the pressure here started in 4 centimeters of water and then was increased to 5. And here we have the leak, okay? And here we have the tide volume. So let's stick to this one here and see what's going on. So you see that the technician increased the pressure. So there are rules of the American Academy of Sleep Scoring. There are some rules for this titration, okay? So the technician follow these rules, and in each 5 minutes, they are going to increase the pressure and see how the respiratory events, the saturation, and the snoring, and the heart rate, how everything is working because of the pressure. And then, here you see the pressure is increased to 7 centimeters of water, and then to 8, and then to 9. Oh, something different happened here. What? See the difference? So when the pressure was 9, the patient is at the same position. The hypopneas, they start to disappear. The apneas disappeared. The patient deepens the sleep. The desaturation starts to be okay again, and the heart takes some time, but it starts to be in a flattering curve. So the pressure was increased to 10 centimeters of water, and we see again, when we see a hypnogram of a patient with this REM sleep stage, huge ones, see, it's 1 o'clock in the morning, 2 o'clock in the morning. But did I say you that REM sleep stage occur mainly in the second half of the night? So what's going on here? We call it REM sleep stage rebound. It means that the patient is so tired for such a long time that when it gets the opportunity to deepen the sleep, it does it immediately. I was a volunteer. I told you that I was a volunteer for a 42-hour sleep deprivation study in my university in São Paulo. And guess how long I took after these 42 hours of sleep deprivation that I had to take care of my friend. Guess how long I took to enter in my first REM sleep stage? Less than 1 minute. I remember I was there and the technician was putting all the electrodes, and I don't remember the technician leaving the room. I was so exhausted that I slept immediately. So that was very, very funny. So I had a huge REM sleep stage right at the first minute of my PSG. And now the pressure was again increased to 11 centimeters of water. The PAP device works from 4 to 20, but 11 is something huge. It's something that it's quite different. You feel the pressure of the air coming through. So the patient was okay with 11, and we see lots of REM sleep stage, and lots also of this green one is the slow wave sleep. So it's trying desperately to catch up sleep. And sometimes we have these reports, and we go like, I always try to treat my patients with the less pressure that I can. So in this case, I would look to this hypnogram and say, maybe 10 centimeters of water is okay, isn't it? It looks like. But why this report is telling me to use 11, to set the device at 11? Because there is something that I cannot hear in this exam. Maybe with 10 of pressure, there was still snoring or a little bit of noisy of the airway. And with 11 centimeters, it is gone. So when you have a titration saying, put 11 centimeters of water, please just put it, okay? Because when I started, I always put it the last one because I didn't want them to, like suffer too much because the pressure is annoying. And
Hypovolemics also reduces at 11.
yeah, now I use 11. I go exactly for this one. I'm not sure I understood your question.
So we were asking about that why didn't you say? So I said that hypovolemics also reduces at 11.
Yeah. In this case, yes. Yeah, in this case, yes. But sometimes you see everything resolved with 10 or another number, okay? And then when I saw that everything was resolved, I used to put the prior, the lowest one. But I didn't know about this snoring that is not showing here. So if the technician tells you in the report that 11 is the number, what I'm saying is that you just have to follow this, because I didn't and I learned, okay? So, coming to an end, we are seeing now a different montage of polysomnography. So this is called split night PSG. And split night stands for half of the night is a baseline PSG and half of the night is a PAP titration. So here we can immediately see that until 1 o'clock in the morning we had the baseline. So we had the saturation, we had turning to the patient in N1 and N2 sleep, trying but not getting REM sleep, lots of obstructive supine position. And we see that the patient was wakened here during the night to put the PAP device and put the mask, and it took more than an hour. So this was difficult for the patient. We can see this here. And then the pressure starts to increase, and we see the same thing that we saw in the last one. The apneas are not appearing anymore. Hypopneas start to disappear. We have a flattening of the saturation. But see how the heart is. The heart is saying, what's going on here? How can I function properly? I'm used to run a marathon during the night. How can I rest now? Oh my God, is it possible for me to rest? Some things like that, okay? So this is a split night PSG. What do you think about this examination? Remember that I told you that the first half of the night we usually get slow wave sleep, and the second half of the night we usually get REM sleep. So this is a thing for split night examinations. It's good when the patient doesn't have the time or the money or can be treated need to be treated very quickly, okay, then a split night will suit. But split night is not foreseeing the baseline. The first idea of this examination was that we could see the baseline and the pap titration during one night, but this is no truth. The baseline here is the baseline only for the first night, first half of the night. The second half, that is also extremely important, is not shown here. So sometimes depending on the case, of course, but I do ask that patients that come with the split night, I write a letter to the physician explaining why I need 2 polysomnography examinations. I need a baseline one, a full night baseline one, so I can have the picture of the patient, and I need a full night pap titration to see how this airway is behaving during the whole night. You get that? So this is another example of the pap titration, the split night, and this is the baseline, and this is the pap titration. You see that the pressure here goes up and up and up until 15 centimeters of water. And when the pressure gets higher as 12 centimeters of water, a different kind of apnea appears that is mixed, that stands for obstructive or obstructive hypopneas, so obstructive apneas or hypopneas plus central ones. So treating patients with PEP devices are not very easy because depending on the pressure, you're going to treat an obstructive event, and as you get higher pressures, you can develop central events. So I say to my patients that I'm always in the middle between central events and obstructive ones. If I try to increase the pressure to eliminate the obstructive ones, in some patients, I increase a lot the central ones. So these cases are very difficult because we have to choose in which way we want to go. And this is a disease called treatment emergent central apneas. That means that the central apneas are developed because of the treatment for obstructive apneas, because of the PAP treatment. It is heart, cardiovascular patients, and neurological ones, especially stroke ones. Okay, because of other causes of apnea that we are talking tomorrow morning, and the delay in the return of the blood to the heart, so it can lead to central apneas.
Could be because of the possibility of the higher pressure in the normal people because we are giving too much of the positive pressure, it can increase the thoracic pressure. Because of that, the venous center can be reduced. This could work. It can happen in the normal people also.
Yeah.
But it's, I mean, if it is a case study, what are the characteristics of the patient?
We don't have, no, I remember, of course, but we don't have a specific characteristic. What I can tell you is that cardiovascular patients, so patients that have problems in the heart, in patients that had a stroke, they are at higher risk of developing this central apnea because of the treatment of the obstructive one, okay, these treatment emergent ones. But I have a patient that is having this right now. He's a young guy, he's 28 years old. He has no neurologic problems, no cardiovascular problems, but he has a rare disease called, I'm trying to explain it, neurofibromatosis, and we don't know what's going on. And he was doing very good in the PAP device, treating only obstructive sleep apnea. And with 2 months of treatment, he started to increase central apneas. But he didn't have any central apneas at the baseline examination. So I know that these central apneas are induced by the treatment of the obstructive ones.
So the pulmonary function test is being should be recommended in these type of patient who might develop central apnea with a titration of
Yes,
we can.
yeah, we can. It's really a hard thing. And treating these patients are a challenge. Yes. Okay, speak it louder. Can you use the microphone so I can hear you?
Ma'am, we have tried the patient second half of the cycle. Audible?
Yeah.
Ma'am, we have titrated the patient in second half of the cycle, and we are seeing that the inspiratory and expiratory pressure is equal in both ways, IPAP and EPAP. So shall we always use, shall we begin from the CPAP only, like that is continuous positive pressure? In IPAP and EPAP pressure is equal. So my
Yeah,
doubt is,
here, just a second. Here, the IPAP and EPAP are the same because this is a CPAP device.
CPAP device,
Okay?
yeah, ma'am.
If we were titrating a B-level device, then they would be different.
So, ma'am, my doubt is maybe the patient has their inspiratory effort or expiratory effort. Maybe there is variance in inspiratory and expiratory. So, shall I always start with CPAP only to check the REM stage?
Yes, normally, yes. We start with that only.
CPAP only.
CPAP ones, yes.
Okay.
At the beginning, like if I'm thinking about 10 or 12 years ago, we would start with the B-level devices, the BPAP ones. But now we always start with the CPAP ones, okay? And then goes changing it.
Okay, thank you, ma'am.
Can you speak in the microphone because it is too many noises here?
Ma'am, at 12 centimeter pressure, like H2
Can
or
you
water
speak
pressure.
slowly, please?
Okay. At 12 centimeter water pressure,
Okay.
why there is mixed apnea seen? Like in this
Here you see
12
at 12.
yeah.
So this is mixed apneas are a kind of apneas that happen when we have both the obstructive and the central components. So here, as we are increasing the pressure, the airway is going to answer in a manner. And in this case, and we don't know specifically why, in this case of this patient started to develop central apneas. So these central apneas are not showing here, but they are here with the obstructive ones. So he presented a lot more of mixed events at the second part of the night because of the titration. So this is in some patients, so your question is related to what he just asked. So this is a kind of patient that we don't know when they are going to present this. We have to treat them and be with them to see if something happens. So this patient presented these mixed events after the treating with 12 of pressure of the PAP device. You understand?
Yeah. So is
We are going to talk about this tomorrow, that we have this respiratory, and then I will show you lots of examples. But I think it's better if we first explain what is each of these events so everyone will talk the same language. So please hang on until tomorrow morning. Here, I also have, in a very short picture here, but we also have a baseline PSG of a patient. So you can see here some desaturations. So here are desaturations, that area under the curve that I told you. We also see here that the breathing abnormalities happen during REM sleep stage. So this is another thing that is very interesting. So we call this REM sleep apnea. Okay, we are seeing that tomorrow because we have these desaturations exclusively in REM. So we need to have a percentage of that to classify this. There is a rule in the scoring the events for that. So we see the same patient when we have the PAP titration, everything so treated. We see it goes into REM sleep, and then here the obstructive, central, mixed, and hypopneas. That this patient had a lot of hypopneas and a little bit of apneas. It disappears. So this is an example how the PAP therapy can reverse or treat the respiratory events. Okay, so the optimal PAP here was 10 in this case, but it could be 4, it could be 16. So this is something that I want you to take a picture. So this is something you need to know for the rest of your life if you want to work with sleep. I put it here, the normal PSG values, so you can have it and look at it to help you to interpret the PSG examinations from now on. Okay? So you have a lot of reading material about this lecture, and we can't. It's very difficult. Sometimes patients comes into the office, they said, I snore, I think I have apnea, but to treat with the PAP devices, we need to have a diagnosis. And for sleep apnea, we need objective evaluation. So maybe, for example, I have some friends in Africa, if they don't have the PSG over there in some cities, in some states, they just don't have it. And how do we treat then African patients? So we have a lot of portable devices. That is the next class. Okay, but we need, the first thing that we need is a diagnosis. And for the apnea diagnosis, we need an objective examination. Okay?
What is REM sleep stage rebound? REM sleep rebound, the thing you mentioned about.
A rebound is when the patient goes into REM sleep stage very quickly at the first time of the night and have longer times of these REM sleep stages. So the most thing that you see in the hypnogram is that red, hey guys, please.
Listen.
The main feature that you see in the hypnogram is that red line of the REM sleep. So that means a REM sleep rebound, okay? Yeah. And REM, sleep behavior disorder, is also called a kind of parasomnia. But the difference is the stage that they happens.
And what about with all the night walking, sleepwalking?
Parasomnias. They are parasomnias. No. Just parasomnias. The REM sleep behavior disorder happens in the REM sleep stage, where we
Cannot happen. Like the patient is
yeah, in REM sleep behavior disorder, yeah, the patient can walk, but the patient will act their dreams. So if the patient is dreaming about flying, he's gonna fly. He's gonna go to the window and fly. That is the thing. Because we can do anything that we want in our dreams. Okay?
Excuse me, ma'am. Literally.